Good morning and welcome. This is Dr. Raju Devde, Professor of Pharmacology, Kaktiya Medical College, Warangal. The topic of today's discussion is insulin. But before going into the details about insulin, we need to know a little bit of the introduction of diabetes, its presentation, the scenario of diabetes globally, as well as the India per se. And before that, you should know these two gentlemen, Banting and Best, who have contributed a lot in production of insulin. And apart from that, there is one more person to be named here, that is MacLeod. So this Banting, MacLeod and Best, they have got Nobel Prize for their work and the contribution in the development of insulin. And apart from that, this is one gentleman whose name is Leonard Thompson, was the first patient to receive insulin in Toronto, Australia, after it has come, after the discovery in 1921. Then apart from that, if you look at diabetes, it is defined as a group of syndromes characterized by hyperglycemia, altered metabolism of the carbohydrates, the proteins and lipids, which increase the risk of complications from vascular diseases. Not only vascular diseases, like there are two complications associated with diabetes. Number one, macrovascular complications and microvascular complications. Macrovascular complications are the vascular diseases like the coronary artery disease, the cerebrovascular disease, and the peripheral vascular disease. When it comes to microvascular complications, they are the retinopathy, the nephropathy, and the neuropathy, the peripheral neuropathy. So this is what actually diabetes is labeled as a syndrome characterized by hyperglycemia, altered carbohydrate, protein, and lipid metabolism with associated complications like the microvascular and the macrovascular complications. Apart from that, if you look at diabetes is called as Madhumeha, and it is well mentioned by Sushruta in Ayurveda, and Erasius also mentioned diabetes way back in the 1st century. And Dobson is a gentleman who has found that urine contains sugar or glucose in the year 1755. Now, with this context, I would like to tell you regarding diabetes, which is also called as a metabolic syndrome. So what is this metabolic syndrome? So metabolic syndrome, it is a pre-diabetic condition which has 5 criteria. Metabolic syndrome consists of 5 criteria. They are: number 1, hypertension, obesity, HDL, high density lipoprotein, less than 40 milligrams % in males and less than 50 milligrams % in females. Number 4, the triglycerides, they are greater than 150 milligrams %. And number 5, the fasting blood sugars greater than 100 milligrams %. So these are the 5 criteria which are going to increase the risk of development of cardiovascular disease. So what are these 5 criteria? Hypertension, obesity, low HDL cholesterol, high triglycerides, and the fasting blood glucose greater than 100 milligrams %. And out of these 3 criteria, if 3 criteria, out of these 5 criteria, if 3 criteria are present, then it is called as the metabolic syndrome. And this will result in development of a increased risk of cardiovascular events. With this brief introduction, we will just move on to the next slides, that is the classification of diabetes. As you know, diabetes is classified into various types like type 1, type 2, type 3, type 4, and so on and so forth. So when you look into type 1 diabetes, was earlier called as insulin-dependent diabetes mellitus, which is again categorized into two types, that is autoimmune diabetes or type 1A diabetes, which is purely linked with an autoimmune disorder. Apart from that, the second category, non-autoimmune or idiopathic, which is called as type 1B, which is associated with development of certain viral infections like Coxsackie B or some other viral infections, that is autoimmune and non-autoimmune or idiopathic. So two types of type 1 diabetes where patient has to totally depend upon the insulin replacement therapy. Now, when you look into the type 2 diabetes, earlier named as non-insulin dependent diabetes mellitus. So this type 2 diabetes, the main cause is due to either a decreased production of insulin, or there might be a normal production of insulin with insulin resistance, or it may be presenting with both, either a decreased production plus insulin resistance. So the main cause of type 2 diabetes is decreased production of insulin associated with insulin resistance or both. So these are the major causes of type 2 diabetes mellitus. So when you talk about this type 2 diabetes mellitus and the metabolic syndrome, so it reminds me of a patient who entered in my clinic and was telling me, sir, that diabetes, hypertension, and cardiovascular disease runs in my family. Looking at that person, the patient, and his attendants, I have seen them and I told them, no, it is not that diabetes, hypertension, and cardiovascular disease running in your family. I could see that no one runs in your family. So with this note, I would like to tell you that diabetes, hypertension, and cardiovascular diseases do have a genetic role to play. But apart from that, the environment also plays a very important role in causation of these diseases. And that is why these diseases are called as lifestyle diseases. That means to say, the genetics loads the gun, whereas the environment pulls the trigger. That is, the genetics, it loads the gun. The genes load the gun, and the environment trigger or pulls the trigger of the gun. So that is how it goes. So that means to say, diabetes, hypertension, cardiovascular diseases are called as lifestyle diseases. It is not only we have to blame on the genetics, but we need to take care of our health, and you have to get adjusted with the environment. Your lifestyle is very important. Then with this brief introduction, I would just move on to the classification of diabetes, that is type 3 diabetes mellitus, or it is also called as other specific types of diabetes mellitus, which are defined as a specific defined gene mutations, which are seen especially in MODY, that is maturity onset diabetes of the young, that is MODY 1, MODY 2, MODY 3, MODY 4, 5, 6, and MODY X. So where all these MODYs definitely have some form of mutations which are occurring in the gene. For example, MODY 1 has HNF4 alpha gene mutation, that is hepatic nuclear factor 4 alpha gene mutation. When we look into this MODY 2, it has a glucokinase gene mutation. MODY 3 has a hepatic nuclear factor 1 alpha gene mutation. Likewise, we have so many MODIs to be discussed, like insulin promoter factor 1 IPF1 gene mutation in MODI 4, hepatic nuclear factor 1 beta gene mutation, MODI 5, and neurogenic differentiation 1 gene mutation, which is in MODI 6, and MODI X is an unidentified gene mutation. So these are regarding these various mutations which occur in various genes which are related with development of different MODIs. And apart from that, we have insulin gene mutation, insulin receptor gene mutation is also one of the types of diabetes which can be seen. Then apart from that, if you move forward with the classification, diabetes secondary to the pancreatic disease. So they are called as secondary diabetes. So it is associated with chronic pancreatitis, surgery associated with pancreas, a tropical diabetes where it is presenting with chronic pancreatitis with nutritional or toxic factors like ingestion of alcohol and so on and so forth. Then apart from that, diabetes secondary to endocrinopathies are also seen with Cushing's disease, excessive glucocorticoid administration, and acromegaly. Then diabetes secondary to immune suppression, especially when after a graft or a renal transplant or the grafting. So we need to give immune suppression. So post-immune suppression, especially diabetes secondary to immune suppression, and diabetes associated with genetic syndromes like Prader-Willi syndrome is a one syndrome which is associated with development of diabetes apart from various endocrinological manifestations like Prader-Willi syndrome. Apart from that, diabetes associated with drug therapies, for example, corticosteroids and then your thiazides and so on and so forth. There are various drugs which may result in development of diabetes secondary to drug therapy. And there is one more entity to be mentioned here, that is LADA, that is latent autoimmune diabetes in the adults. So this LADA, so when you look into type 1 diabetes, it usually occurs less than say 18 years or 17 years. It will not go beyond the 20 years. So, but here when you look at LADA, latent autoimmune diabetes in the adults, it is like an autoimmune type 1 diabetes, but the onset of age is a bit delayed in this, and the patient may not exactly require insulin in this condition. So where we can give either insulin sensitizers, or we can give either insulin secretagogues and so on and so forth. So LADA is another entity to be mentioned here. And lastly, we have type 4 diabetes, which is called as gestational diabetes mellitus. So this gestational diabetes mellitus has to be tested in a pregnant lady. We need to go for an oral glucose tolerance test. And depending upon that, we need to give insulin, and the insulin requirement in the gestational diabetes mellitus is very minimal. But we have to treat a GDM as to prevent complications both in the mother or in the pregnancy as well as the fetus. So this is the classification of diabetes. Now, moving forward to the incidence or what is the presentation of diabetes globally. So it approximately affects around 5 to 8% of the population globally. The incidence of diabetes increases worldwide, or it's increasing worldwide, and there are around 500 million patients globally. And 80% of these patients with diabetes are found in the developing countries. And India contributes around 75 millions of patients. And the expected projection is around 109 million diabetic patients, which India is going to contribute. That is around, say, 1/4 or 30% of the contribution is coming from India itself, I can say. Then apart from that, most of the patients, they are asymptomatic, and the diagnosis of diabetes is most of the around 50% of the diagnosis of diabetes is seen during accidentally. So when the person is admitted to the hospital with, say, a high-grade fever or some fracture or some stress or an infection, he's been diagnosed to have diabetes. So most of the patients, they present with diabetes accidentally and they are asymptomatic. And as I already told you, the tendency of diabetes, it keeps on increasing or double fold or triple fold, quadruple fold with obesity. So why obesity mainly contributes to diabetes is because of the development of insulin resistance. So here, the abdominal fat results in development of incidence, or the abnormal or retroperitoneal pad of fat, which results in development of insulin resistance, or even both insulin resistance and decreased production of insulin. And apart from that, when you look at diabetes, happens to be one of the leading cause of death per se, and one of the leading cause of blindness. I can say that the first and foremost complication which is associated with diabetes is a retinopathy. That is, diabetic retinopathy is the first presentation. The first complication to set in is the retinopathy. So one need to know regarding this, which will become a question for you in the postgraduate. So diabetic retinopathy sets in the earliest complication of diabetes, and it is also one of the leading cause of cardiovascular disease and renal failure. So once the patient can withstand this cardiovascular disease, then he will land up in development of end-stage renal disease or diabetic nephropathy. Now, moving forward, so how is this diabetes, is type 1 diabetes and type 2 diabetes? So the onset of disease in type 1 is usually less than 30 years of age, and is more than 40 years of age. Whereas type 1 diabetes is around, say, 5 to 10%, and type 2 diabetes is around 90%. The onset of type 1 is abrupt, that's suddenly, or whereas type 2, it is gradual in onset. When you look into the nutritional status of the patients, these patients are type 1 are usually thin, whereas type 2, they are usually obese. When you look into the clinical symptoms, the classical clinical symptoms of type 1 are polydipsia, polyphagia, polyuria, and weight loss. Whereas in type 2, they are often symptomatic. But when you look into the early diagnosis of type 2 diabetes, the patients may present with balanoposthitis and recurrent balanoposthitis in male, and recurrent vulvovaginitis and urinary tract infections usually in females. And apart from that, when you look into, there might be skin manifestations like acanthosis nigricans. Then coming to the ketosis, the ketoacidosis or DKA, the presentation is very frequent in type 1, whereas it is usually absent in type 2, but it may also present with HHS, that is hyperglycemic hyperosmolar syndrome in type 2 diabetes, if the type 2 diabetes is uncontrolled, or there's abrupt stoppage of the drugs, or there's some concomitant infection or stress. When you look into the endogenous insulin, it is usually absent in type 1, but it can be present but relatively ineffective, or maybe decreased production in type 2. Then related lipid abnormalities, there is hypercholesterolemia, which is frequent, and all the lipid fractions are elevated, especially in ketosis or diabetic ketoacidosis. Whereas in type 2, the cholesterol and triglycerides are often elevated. The carbohydrate-induced hypertriglyceridemia is very common. So we never come across isolated hypertriglyceridemia. Generally, the Indian context with related to disease diabetes and the lipid abnormalities are mixed dyslipidemias. That means to say there's elevated total cholesterol, there's elevated triglycerides, there is elevated LDL cholesterol, and reduction in high density lipoprotein cholesterol. So we definitely do have a mixed hyperlipidemia or mixed lipidemias rather than isolated hypertriglyceridemia, which is very rare. Then when you look into the insulin therapy, in type 1, it is mandatory and it is must, it is required. But in type 2, the requirement of insulin is only 20 to 30% of the patients if there is uncontrolled diabetes with oral hypoglycemic drugs. When you look into the hypoglycemic drugs, they should not be used in type 1 diabetes, whereas they are clinically indicated in type 2 diabetes. When you look into the diet becomes very mandatory with insulin, whereas it is mandatory with or without drugs in case of type 2 diabetes. So when we move into, so this is how exactly the characteristics and of type 1 and type 2 diabetes are. Then when you look into the criteria for the diagnosis of diabetes, when you look into the criteria, yeah, the criteria of diagnosis of diabetes, it mainly depends upon the fasting plasma glucose. The fasting plasma glucose, if it is greater than 126 milligrams per deciliter, or the postprandial plasma glucose, which is also called as 2R plasma glucose, greater than 200 milligrams per deciliter of glucose, or the random plasma glucose, which is greater than 200 milligrams per deciliter of blood glucose. That means to say fasting plasma glucose or fasting glucose, which is greater than 126 milligrams per deciliter, or 2R plasma glucose or postprandial plasma glucose greater than 200 milligrams per deciliter, random plasma glucose greater than 200 milligrams per deciliter of glucose, or glycosylated hemoglobin, which is also called as HbA1c, greater than 6.5%, contributes to the diagnosis of diabetes. So here, when I talk about these millimoles, 1 millimole is equal to 18 milligrams per deciliter of glucose. 18 milligrams per deciliter of glucose is 1 millimole. That means to say fasting greater than 126, post lunch greater than 200, and random blood sugar greater than 200 milligrams per deciliter, and A1C equal to or greater than 6.5%. Now there is one more entity in the diagnosis, like to have a better outcome with relation to the complications of diabetes. If you can catch the bird in the early stage, that is, what is this catching the bird in the early stage and appropriately treating or subjecting the individual for lifestyle modification, is there are two entities which are called as IFG and IGT, that is impaired fasting glucose and impaired glucose tolerance, IFG. So what is this IFG? If the plasma glucose, fasting plasma glucose ranges between 100 milligrams to 125 milligrams per deciliter, it is called as impaired fasting glucose. And 2-hour plasma glucose or postprandial plasma glucose ranges from 141 to 199 milligrams per deciliter, which is called as impaired glucose tolerance. And this is where you have to catch the patient to treat him and to see that he does not land up in development of major complications. Now, before going into the insulins per se, we would like to go into a brief history regarding the development of insulin. So way back in the 15th century, there was a clinical description of a polyuric state, polyuria, by Abas Papadis. In 15th century AD, that was BC and this is AD, the obese and thin patients were distinguished by Shushrita Charaka, especially in India. And in 1815, excess sugar in the urine was nothing but glucose, was described by Michael Chevrel in France. And in 1869, the islet cells of Langerhans were identified by Paul Langerhans in Germany. And in 1907, the putative hormone, which was named as insulin. And in 1922, the isolation of insulin and use of insulin by Banting, Best, Calip, and MacLeod. So we have to name these four persons with the isolation and use of insulin, that is Banting and Best, Calip, and M.J. MacLeod. Now, the discovery of insulin in 1921 by Frederick Banting, Charles Best, and J.G.R. MacLeod. And Leonard Thomson was the first patient to receive this injection insulin in 1922. The regular insulin was discovered in the year 1926. NPH, that is the intermediate acting insulin or neutral protamine hagedon, in 1946. Later, lenti-insulins were described by Noah Sanger in the year 1955. Berthelonello, that is radioimmunoassay of insulin, was done in 1978, and the biosynthetic human insulin was brought out in the year 1981. And Eli Lilly was the pharmaceutical company in 1982, has genetically engineered human insulin through E. coli, and the genetically engineered human insulin through yeast was none other by Novo Nordisk in the year 1984. That means to say, these two pharmaceutical companies like Eli Lilly and Novo Nordisk are the pioneers in the production of insulin in large scale for the treatment of patients. And apart from that, purification and standardization of insulin was done in the year 1982 onwards by a method called as HPLC, that is high performance liquid chromatography. And the other pancreatic extractors, like the American scientist E.L. Scott, was partially successful in extracting insulin with alcohol. A Romanian, R.C. Polescu, made an extract from the pancreas that lowered the blood glucose of the dogs. And some of them claim Polescu may have been the first to discover insulin about 10 years before Banting and Best, but he did not project his findings, and that is how he has lost the Nobel Prize for insulin. So before the discovery of insulin, he is a patient with type 1 diabetes. And after insulin, you can see the drastic change in this particular individual. So Leonard Thomson, this is a person, Leonard Thomson, the first patient to receive it in 1922. And after 2 months, you can see the drastic change. That is because that is why we say insulin to be an anabolic hormone. And before insulin was discovered in 1921, everybody or everyone with type 1 diabetes died within a weeks to years of its onset. But when this Leonard Thomson in the year 1922, Banting and Best injected this 14-year-old charity patient who weighed around 46 lbs with 7.5 ml of insulin in each buttock. No doubt, abscesses have developed, and he became very acutely ill. But later on, however, his blood sugar has dropped enough to continue refining what was called as isletin or insulin. And not only that, after 6 weeks, a refined extract caused his blood glucose to fall from 520 milligrams per deciliter to 120 milligrams per deciliter in 24 hours. And Leonard lived a relatively healthy life for around another 13 years before dying of pneumonia, because in 1922, the treatment was started, and 1935, he died with pneumonia. So he survived for more than 13 years. And at that time, he died of pneumonia because the antibiotics were not developed. So the development of antibiotics started way back somewhere near the Second World War, and so on and so forth. Now, when you look into this nutshell, in a nutshell, the important events like the discovery of islets in 1869 by Paul Langerhans, discovery and isolation of insulin, Banting, Best, and J.J. McLeod, 1955, determination of primary amino acid sequence of insulin by E. Sanger. So the Sanger is a very important person who has determined a primary amino acid sequence of insulin, 1955. 64, X-ray crystallography was used in structure determination of important biomolecules, especially insulin, by D. Crawford Hodgkin. And in 1967, discovery and structure determination of proinsulin by Steiner and Chance. And 1969, there is determination of three-dimensional structure of insulin by Crawford Hodgkin. 1979, cloning of insulin gene was taken up by W. Ritter and H. Goodman. With this brief introduction, we'll look into the introduction of insulin. So we'll go into the details about insulin now. So as you know, insulin, it is a hormone. This is a hormone which is called as a polypeptide hormone, which is mainly secreted by the beta cells present in the pancreatic islets of Langerhans. The main function of the insulin is to lower the blood glucose. It is to lower the blood glucose or the serum glucose and to promote the anabolism. And insulin is an essential growth factor which is required for normal development and growth of an individual. Apart from this, insulin has many firsts to its credit. So what are these many firsts to its credit? As I already told you, this is a hormone which is the first protein shown to have hormonal action. Number two, it is the first protein to be crystallized in pure form by Abel in 1926. Number three, it is the first protein to be fully sequenced by Sanger et al. In 1955. The protein to be fully sequenced. Number four, it is the first protein to be synthesized chemically by Du et al. Jan in 1964. And number five, it is the first protein to be synthesized as a large precursor molecule by Steiner et al. 1967. And it is the first protein to be synthesized for commercial use by DNA recombinant technology in the year 1979. So insulin has many firsts to its credit, and insulin should have been named the protein of the 20th century. So please remember, there are around 6 firsts or credits which goes to insulin. First protein as a hormone, first protein to be crystallized in pure form, first protein to be fully sequenced, first protein to be synthesized chemically, first proteins to be synthesized as a large precursor molecule, and the first protein to be synthesized for commercial use by DNA recombinant technology. So with this first regarding the insulin, and you know that this pancreas is the main gland which produces insulin, and pancreas is called as a dual gland because it has also endocrine gland and an exocrine gland. So as an exocrine gland, it provides both the enzymes that digest the food in the gut, that is the pancreatic enzymes like pancreatic lipase, pancreatic amylase, and pancreatic polypeptide, that is pancreatic juices, the pancreatic secretions meant for digestion of the food in the gut. So the ductal and acinar cells of the exocrine gland comprise about 80% of the gland. And not only that, secondly, this endocrine part of the pancreas contain the hormones that control the utilization of the nutrients supplied by this digested food. For example, The islets of Langerhans of the endocrine portion are scattered throughout the exocrine matrix to an extent of 2%, which are responsible for its actions in the periphery. Now, with this brief introduction regarding the insulin, we will go into the pancreatic axis. So, what are these hormones? Especially the pancreas produces various hormones like insulin, glucagon, somatostatin, and pancreatic polypeptide. We'll look into that later. But when you talk about this pancreatic axis, so insulin, whenever there's a high blood glucose, there is a stimulation of gastrointestinal hormone secretion, which in turn stimulates the pancreas to produce insulin. And this insulin acts on the peripheral target tissues like the muscle. The insulin induces glycogen synthesis, and which is stored in the liver. The insulin also acts on the kidneys, where it increases the absorption of glucose from the filtrate, and the glucose is reabsorbed into the blood circulation and made utilized with various tissues. And with respect to other tissues, insulin increases the transport of glucose and amino acids into the cells. So this is one aspect where insulin, which is secreted by the beta cells due to high blood glucose level, takes up glucose into the tissues, and the glucose, it increases into the tissues and the cells. Apart from that, when you look into the other part where there's a low blood glucose, which stimulates the alpha cells to produce glucagon, which in turn glucagon acts upon the liver. So this alpha cells which produce or secrete glucagon, whenever the blood glucose is low, the glucose is released from the tissues back into the blood. How it is released? The glucagon will act upon the liver. In a process, it induces glycogenolysis and release of glucose into the blood. So as you know, the glucose is stored in the form of glycogen in the liver, and glucagon acts on the liver, and it causes the release of glucose from the liver by a process called as glycogenolysis. Now this is how, if you look at glucose, the glucose is helping in the utilization of glucose. Insulin is helping in the utilization of glucose to enter into the cell through a mechanism which is called as GLUT4. So GLUT4 is very essential for utilization of glucose through pancreatic beta cells, that is especially through the insulin, GLUT4. And there's another GLUT2. So there are various types of GLUTs. GLUTs are nothing but glucose transporters. Glucose transporter 1, GLUT2, GLUT3, GLUT4, GLUT5. So we are very much concerned regarding this GLUT2, which is actually for the insulin secretion from the beta cell, that is the islets of Langerhans in the pancreas, where it utilizes the GLUT2. And the peripheral utilization of glucose is brought about by GLUT4. Now, when you look into the glucose homeostasis, so what is this glucose homeostasis? Glucose homeostasis is nothing but maintenance of normal blood glucose level, that is about 90 milligrams to 100 milligrams per deciliter of blood. So how is this glucose homeostasis maintained? So there are two situations here. Number one, whenever there is a rising blood glucose, so when the blood glucose rises after eating a high carbohydrate meal, the blood glucose level rises. So whenever there's a rise in the blood glucose level, the beta cells of the pancreas are stimulated to release insulin into the blood. So this insulin in turn will act upon the body cells to take up more glucose. And this more glucose, which is there, which is utilized for generation of ATP and the functions of the body. And the excess of glucose is stored in the form of glycogen in the liver. Not only that, these body cells which take up more glucose in a period of time, the blood glucose level declines to a set point, which stimulates, and the stimulus for insulin release diminishes. Okay, so this is how one situation where there's a rising blood glucose after a heavy carbohydrate meal, the production of insulin, and what are the various effects, and it maintains the homeostasis. On the other hand side, the stimulus of maintaining homeostasis is declining blood glucose level, that is after skipping a meal. So what happens after skipping a meal? So when someone skips a meal, there's a decrease in the blood glucose level. This will cause the alpha cells of the pancreas to get stimulated to release glucagon into the blood. So this glucagon, which is released into the blood, act upon the liver to break down glycogen and release glucose into the blood. So the blood glucose level rises to a set point where the stimulus for glucagon release is diminished, and hence the homeostasis mechanism is maintained. That means to say the body has the endogenous mechanisms which can maintain the glucose homeostasis, either whenever there's a stimulus of elevated blood glucose levels after a meal, or there is a decrease in the blood glucose level after skipping a meal. There are the hormonal mechanisms, one way the insulin, the other way the glucagon, which will see that the normal homeostasis of the blood glucose is maintained within the body. Then apart from this, if you look at the pancreas itself, it is a bulk and is an exocrine as well as a endocrine gland. So the bulk of pancreas is an exocrine gland, secreting both the pancreatic fluid into the duodenum after a meal, and inside the pancreas are millions of clusters of cells which are called as islets of Langerhans, and these islets of Langerhans act as an endocrine tissue containing 4 types of cells in order of their abundance. They are the beta cells, which are around 75 to 80%. They secrete insulin and amylin along with C-peptide. Then we do have alpha cells which secrete glucagon, the delta cells which secrete somatostatin, the gamma cells or F cells, they secrete pancreatic polypeptide. Next, if you look into the structure of insulin, as we all know, the insulin, the structure was synthesized, the structure of insulin was synthesized way back in 1950s. So here, this human insulin consists of 51 amino acids with a molecular weight of 5.7 kilodaltons. It comprises of 2 polypeptide chains. That is A chain, which contains 21 amino acid residues, and B chain, which contains 30 amino acid residues. And these 2 chains are linked by interchain disulfide bridges that connect A7 to B7 and A20 to B19. So this is what the A7, the A chain of insulin, that is 7th position is cysteine, which is connected to the B chain of insulin. That is A7 is connected with B7, that is cysteine amino acids. Then the A20, that is amino acid 20 cysteine, is connected with amino acid 19 of B chain. Okay, and there is an intrachain, the third bonding is there. The third intrachain disulfide braid is between A chain 6 of cysteine and A chain 11 of cysteine. This is called as intrachain. So this is the primary structure of insulin, which consists of 51 amino acids with a molecular weight of 5.7 kilodaltons, comprising of 2 polypeptide chains, alpha chain and beta chain. That is 21 amino acids in alpha chain and 30 amino acids in beta chain, with connecting disulfide bridges between the 2 chains. And there's another intra chain, the third chain, which is present in the alpha chain only of the insulin structure. Now, apart from that, this is a simplified diagram depicting the simplified structure of insulin containing 51 amino acid polypeptide. So you can see C6, 6 and 11, this is the intra chain. And you can see this disulfide bridges C7 or A7 and B7 and 19 and 19. Okay, that is the thing. Now, the synthesis and release of insulin. So how is this insulin synthesized? So the synthesis of insulin, as you know, the synthesis of insulin, it is a polypeptide. Insulin is a polypeptide, and the single chain polypeptide insulin is converted to a pre-pro-insulin, and this pre-pro-insulin is later on converted to pro-insulin by catalases, by the enzyme catalase, and by proteases, and also the furins. So these catalases, so the pro-insulin catalyzes by proteases, they are called as furins, and it is converted into insulin and C-peptide. Why it is called as C-peptide is because it connects the name C-peptide is given because it connects between the A and the B chain. That is why it is called as C-peptide. And this produced insulin is bound with two zinc molecules or atoms. And this insulin which is produced is stored as a polymer in the form of hexameric crystals in especially the what you call like the granules. Okay, so when you look into the biosynthesis or synthesis of insulin, this pre-pro insulin is converted into proinsulin with the removal of 24 amino acids. So this pre-pro insulin contains of 110 amino acids. So with the removal of 24 amino acids, proinsulin consists of 86 amino acids, which is mediated by catalases and by proteases to the production of insulin, which is 51 amino acid chains, that is alpha and beta chains, that is 20 and 31, like that. And not only that, 21 and 30 amino acids, that is resulting in 51 amino acid sequence. And the C-peptide would consist of 35 amino acids. And finally, this insulin and C-peptide, they are mainly stored in the granules, in the beta cells of Langerhans. And finally, the insulin is released with the release of C-peptide in the blood. This is how the synthesis and release of insulin occurs. Apart from that, if you look at the insulin secretion, the glucokinase is the rate limiting step for glucose metabolism by the beta cells of Langerhans. This will result in generation of ATP from the electron transport chain, which closes an ATP dependent potassium channel. So glucokinase is a rate limiting step for glucose metabolism from the beta cells. And with the generation of ATP from the electron transport chain, which closes the ATP dependent potassium channel and opens up the voltage dependent calcium channel, this in turn increases the intracellular calcium, resulting in stimulation of insulin production. So you can see here. So this GLUT2 is essential for the movement of glucose into the beta cell. So this is the beta cell and this is extracellular. The glucose is entering the beta cell through GLUT2, that is glucose transporter 2, whereby this glucokinase, which happens to be the rate limiting step, which acts upon the glucose metabolism in the islet cells of Langerhans with the generation of ATP. So this ATP is generated. So this generated ATP will cause the ATP dependent potassium channel to close. So after generation of ATP, it causes the ATP dependent potassium channels to close. So this potassium channel closes and there's an opening up of the calcium or the voltage dependent calcium channels are opened, and there's an increased intracellular inflow of calcium, which in turn acts upon the mitochondria to cause a release of insulin through a process called as exocytosis. So this is exactly the mechanism of insulin secretion. Okay, so once the insulin is secreted, it is secreted along with the C-peptide, which is released by a process of exocytosis, and the released insulin and C-peptide are poured into the venous systemic circulation, through which this insulin and C-peptide are directly entering into the liver, which takes up approximately 50% of the insulin. And the remainder of the insulin is distributed throughout the body. So when you look into the basal secretion of insulin, it is 40 micrograms per hour during the fasting conditions. And the insulin secretion is increased with meals. Hence, if you know regarding the insulin secretion, the endogenous insulin secretion, it is secreted by two phases. One is the basal phase and the bolus phase. The bolus phase is insulin is secreted when the post meal, the secretion of insulin is in the form of bolus. And in between the meals, there is certain energy which is required for maintenance of the metabolism. So the insulin which is secreted in between the meals, which is called as basal secretion. So bolus secretion of insulin and basal secretion of insulin, one has to very much remember. That is why we say insulin is secreted as biphasic secretion of insulin. And apart from that, the aims of exogenous insulin is to approach the physiological insulin secretion during the treatment of diabetes. But we don't have any insulin present off late or as yet which can mimic the physiological endogenous secretions of insulin. Then, if you look at the regulation of insulin secretion by glucose in the pancreatic beta cells. So this is one. So this glucose is present outside the beta cell, which enters into the beta cell with the presence of a glucose transporter, that is GLUT2. Once the glucose enters through a stimulation of hexokinase 4 or glucokinase, it is converted into glucose 6-phosphate. So this glucose 6-phosphate undergoes various cycles like glycolysis, the citric acid cycle, and the oxidative phosphorylation to produce ATP. So this increased ATP in turn will cause closure of ATP dependent potassium channels. And this ATP dependent potassium channels, when they are closed, there is a generation of a depolarization, and this depolarization will cause the voltage gated calcium channels to open up with a inflow of calcium, the influx of calcium intracellularly, with the various changes which occur in the nucleus, the mitochondria, and resultant stimulation of the granules, and there is a release of insulin from these granules with the process of exocytosis, and the insulin is released for its action on various tissues in the body. So this is how exactly the regulation of insulin secretion occurs by glucose in the beta pancreatic beta cells with the help of GLUT2. GLUT2, please remember, GLUT2 is essential for entry of glucose in the beta cells, which acts as a stimulus for the production of insulin. So this is again a simplified diagram, that is the metabolic regulation of insulin secretion, where glucose enters through GLUT2 in the process of glycolysis, and there is a mitochondrial metabolism resulting in elevated ATP. This increased ATP will inhibit or close the ATP sensitive potassium channels, resulting in the closure of these potassium channels, resulting in depolarization and opening up of voltage gated calcium channels. The calcium is entered into the beta cell, which in turn causes release of insulin through a process called as exocytosis through the granules. So this is a very much simplified diagram to explain especially how glucose in the presence of GLUT2 enters in the beta cell, and this beta cell during a process of cascade of events will cause release of insulin for its further anabolic actions. Apart from that, if you look at, insulin is also secreted from free fatty acids. So here, free fatty acid acyl-CoA can also augment insulin secretion. So fatty acids. So increased intracellular calcium stimulates exocytosis with the help of protein kinase C, the exocytosis is enhanced. For example, if you look at free fatty acids, they enter into the beta cells with a resultant formation of free fatty acid or fatty acid, acyl-CoA. And this fatty acid, acyl-CoA, in turn increases the intracellular calcium to the bone, and which causes the potassium channels to get closed. As a resultant, there is a depolarization and opening of the voltage dependent calcium channels, and this in turn will cause a production of insulin. So free fatty acids augmented insulin secretion also can be seen by free fatty acid acyl-CoA in the presence of increased intracellular calcium through the bone, with a resultant closure of ATP dependent or ATP sensitive potassium channels, with a resultant development of depolarization and entry of calcium through the opening up of voltage dependent calcium channels, and resultant development of ATP and the release of insulin. Then if you look at the insulin secretion, as I told you, it is secreted in two phases. One is the biphasic secretion of insulin. But if you look at, this is actually the normal secretion of insulin. So this is the normal secretion of insulin in the normal individual. If you look at this green graph or the green curve, in one hand side, if you see, this is the glucose and this is the insulin over time. So this is a normal secretion. But when you look at the patient with diabetes, especially the type 2 diabetes, there is a loss of first phase insulin secretion, which is an initial biological abnormality which is seen in type 2 diabetic patients, which manifests, and this will result in elevation of postprandial glucose. So you see, there is a loss of initial phase of insulin secretion in type 2 diabetes mellitus. So in this type 2 diabetes, the second phase will be more prolonged and longer, which can result in post-meal hypoglycemia. So in the type 2 diabetes patients, there is actually the fasting hyperglycemia and postprandial hypoglycemia. So once the patient takes food, he will develop hypoglycemia, is because the blunting of the second phase or the prolonged second phase of insulin secretion. So insulin is produced like this. When you take a meal, insulin production is high and gradually it will taper down. But here the first phase is blunted. So once the first phase is blunted, you see this, the yellow worm, the first phase is blunted, which results in production of hyperglycemia, that is early morning hyperglycemia followed by a post-meal hypoglycemia with a prolonged phase of insulin production in type 2 diabetes mellitus. Now, we will look into the various regulators of insulin secretions. So insulin, the stimulators of insulin secretion. So what are the various things which can stimulate the insulin production? For example, if there is increased blood glucose, increased amino acids, increased free fatty acids, increased serum ketone bodies. So all these things will increase the insulin secretion. Increased glucose, increased amino acids, increased free fatty acids, increased ketone bodies. And the hormones which increase the insulin secretion are gastroinhibitory peptide, glucagon, gastrin, cholecystokinin, secretin, vasoactive intestinal peptide, and epinephrine. So all these hormones, epinephrine, also called as adrenaline, they cause increased or elevated insulin secretion. What are the inhibitors of insulin secretion? So decreased glucose, decreased amino acid, decreased free fatty acid, especially the fasting decreased free fatty acids, they reduce the insulin secretions. And the hormones like somatostatin, leptin, and epinephrine, which is acting on the alpha receptor. So epinephrine, which is acting on the beta receptors, will increase the insulin secretion. Epinephrine, which is acting through the alpha receptors, which will decrease the insulin secretion. Now, we'll go to the next slide. So here we have seen the regulators of insulin secretion. One hand, the insulin stimulators and inhibitors of insulin. When you look into the other hand side, how is this insulin degraded? The degradation of insulin. So before going into the degradation of insulin, so we will look into the alpha 2 agonists. As I told you, they cause decreased secretion of insulin, and beta 2 agonists, they cause increased secretion of agonist. And not only that, the somatostatin decreases the secretion of both insulin and glucagon, and they decreases the beta cells of the pancreas. So this somatostatin will also cause decreased production of both insulin and glucagon. And in large doses, somatostatin will also cause a decrease in the synthesis and release of growth hormone and thyroid stimulating hormone, in turn, which will cause decreased absorption and decreased motility of the GIT. Not only that, leptin, which is by activating the leptin receptors in the pancreas, causes decreased in the insulin secretion. So here, alpha 2 agonists are the ones which cause decreased insulin secretion. Somatostatin causes both decreased secretion of insulin and glucagon. In also, somatostatin in high doses will cause decrease in the synthesis and release of both the growth hormone and thyroid stimulating hormone. So now, before going into the degradation, we will talk regarding the distribution of insulin. So insulin, it is mainly distributed after its IV. So insulin is released in the blood. After release of insulin, endogenous release of insulin in the blood, especially the venous systemic circulation, the T half is around 5 to 6 minutes in healthy as well as in diabetic individuals. And the volume of distribution of insulin is equal to the volume of extracellular fluid, which is approximately 20% of the total body weight. And insulin in the plasma is a free monomer which can diffuse into the tissues and also can concentrate into the blood-brain barrier. Now, when you look into the metabolism of insulin, the insulin, it is inactivated by enzymatic biotransformation by a process called as hydrolysis by metalloproteinases and by a process called as reduction. And it is cleaved at the disulfide bonds, and the renal insulin elimination is very low because after filtration, it is again reabsorbed into the renal tubules, across the renal tubules. It is very well absorbed across the renal tubules. So this is regarding the metabolism, distribution and metabolism of insulin. So how is insulin degraded? The same thing, the hydrolysis of disulfide linkages which occur, the hydrolysis of, the disulfide linkages between alpha and beta chains occur, and around 60% of insulin is degraded in the liver, and 40% of the endogenous insulin is degraded in the kidney. Not only that, exogenous insulin is also 60% is degraded in the kidney and 40% is degraded in the liver. And the half-life, as I told you, it is around 5 to 7 minutes, endogenous insulin. And insulin, it is a category B drug, which is non-teratogenic. And when you look into the usual places of injection of insulin, it is mainly in the upper arm, front and sides of the thighs and the abdomen. It is not to inject in the same place. One should not inject insulin in the same place. It has to be rotated, and the insulin has to be stored in the refrigerator and warm up to the room temperature before it is used therapeutically. And once the insulin vial or the cartridge is used, opened up, it has to be used within 30 days of opening of the insulin cartridge or the vial or the insulin injection. Now we'll look into the other aspects of insulin, the metabolic effects of insulin. When you look into the metabolic effects of insulin, it is an anabolic hormone. So insulin promotes the anabolic state by channeling the metabolism towards the storage of carbohydrates, storage of protein, and storage of lipid synthesis. So So it acts on the carbohydrate, protein, and lipid metabolism, which synthesizes them. And not only that, insulin promotes the energy storage by stimulating the synthesis of fatty acids and triglycerides in the liver and adipose tissue, and glycogen in the liver and skeletal muscle, and protein synthesis in the muscles. And apart from that, at the same time, it opposes the catabolism by inhibiting the breakdown of proteins, the triglycerides and glycogen, and by suppressing the gluconeogenesis in the liver. So when you look into the actions of insulin, that is, insulin acts on the three main target tissues. And what are the insulin effects? If you look at the insulin, its action on the three major organs or tissues of the body, one is the liver. On the liver, it acts by increasing the glucokinase, it acts by increasing the glycogen synthase, it acts by decreasing the glycogen phosphorylase, and it increases the PKF1, PKF2, and F26BP. And not only that, it also increases the HMG-CoA reductase enzyme in the liver. And on the adipose tissue, or in the adipose tissue, this insulin affects as a hormone sensitive lipase, which is reduced. The hormone sensitive lipase is reduced. GLUT4, that is glucose transporter 4 in the adipose tissue, is increased. Pyruvate dehydrogenase is increased. Lipoprotein lipase is increased. So on the adipose tissue, the action is by increasing the glucose transporter 4, increasing the pyruvate dehydrogenase, increasing the lipoprotein lipase, and decreasing the hormone sensitive lipase. And on the muscle, it acts by inhibiting, or it acts by increasing the glycogen synthase, it acts by increasing GLUT4, it acts by increasing the protein synthesis. So these are the various actions of insulin on the target tissues like the liver, adipose tissue, and the muscle. And apart from that, the actions of the carbohydrate metabolism, if you look at the insulin's action on the carbohydrate metabolism in the liver, insulin stimulates glycolysis, it promotes the glucose storage as glycogen, it inhibits the glycogenolysis, and also it inhibits the gluconeogenesis. So stimulates glycolysis, promotes glucose storage as glycogen, inhibits glycogenolysis, and inhibits gluconeogenesis. In the muscle, it stimulates the glucose uptake through a GLUT4, and it promotes glucose storage as glycogen in the muscle. And in the adipose tissue, it stimulates the glucose transporters GLUT4 into the adipocytes, as well as it promotes the conversion of glucose into triglycerides and fatty acids in the adipose tissue. These are the main three actions on the carbohydrate metabolism, where it is an assimilation process. So the glucose is stored, it is assimilated, it is an anabolic process. So that is why we say insulin as a hormone, it is an anabolic hormone which assimilates the energy, and it is stored in the form of glycogen in the liver, in the muscle as a glucose and protein, and adipose tissue as triglycerides and fatty acids. And apart from that, if you look at the insulin effects on the carbohydrate, fat, and protein metabolism, when you look at the carbohydrate metabolism, insulin stimulates the glucose transport in the adipose tissue and the muscle. And the rate of glycolysis in the muscle and adipose tissue, and glycogen synthesis in the adipose tissue, muscle, and the liver. And insulin inhibits the glycogen breakdown in the muscle and the liver, and the insulin inhibits the rate of glycogenolysis and gluconeogenesis in the liver. Is one and the same. When you look at the effects of insulin on the lipid metabolism, the fatty acids and triacylglycerol synthesis in the tissues, insulin stimulates. Insulin also stimulates the uptake of triglycerides from the blood into the adipose tissue and the muscles, and it also stimulates the rate of cholesterol synthesis in the liver. Apart from that, insulin inhibits the lipolysis in the adipose tissue. It inhibits the lowering of plasma free fatty acid levels it also inhibits the fatty acid oxidation in the muscle and the liver, and it inhibits the ketogenesis. Not only that, insulin on the protein metabolism, it stimulates the amino acid transport into the tissues. It stimulates the protein synthesis in the muscle. It stimulates the adipose tissue, the liver, and the other tissues. Not only that, insulin inhibits the protein degradation in the muscle, and it inhibits the urea formation. So these are the various effects of insulin on the carbohydrate, lipid, and protein metabolism. And apart from that, if you look at, this is a simplified schematic diagram with the action of insulin with respect to facilitated action of insulin and inhibited action of insulin. For example, one side you have glucose. So insulin stimulates glycogenesis, and it is stored in the form of glycogen in the liver. Insulin inhibits glycogenolysis. Okay. Insulin stimulates the amino acids for the production of proteins, protein synthesis in the muscle. And insulin inhibits the protein degradation into amino acids. Not only that, insulin stimulates the production or formation of fatty acids, and in turn the fatty acids are stimulated for the synthesis of triglycerides in the adipose tissue, and they are stored as fatty acids, and insulin inhibits the conversion of fatty acids into proteins. And the fatty acids are inhibited by insulin for a degradation into triglycerides. Okay, so this is actually the schematic diagram to show the stimulatory effects of insulin as well as the inhibitory effects of insulin on the various target tissues. Now, apart from that, if you look at the insulin receptor, so I think I will stop my lecture here. So I will deal with this topic in my next class, that is the insulin receptors, then the insulin structure, then the mechanism of action, and other types of insulins I will be dealing in my